So the remit of the talk today is to give you a brief introduction to bronchiectasis and what great care should look like. So that's where I work, around from Edinburgh, a brand new hospital, and that's our lovely castle that overlooks the city. So bronchiectasis, this is someone that had their lung taken out with bronchiectasis, and bronchiectasis happens because the airways are permanently enlarged, and that allows infection to occur, and that's why patients get chronic cough, chronic sputum production, recurrent chest infections, and Tony DeSoy's has done some nice work showing that there are other symptoms patients have, particularly fatigue, malaise, chest pain, and a more advanced disease that can impair quality of life. This is some nice work looking at the prevalence or incidence of bronchiectasis, and what we're seeing in all our clinics throughout the country is that we're seeing a lot more middle-aged and elderly patients, and actually this is looking at data from 2004 to 2014, and this is the middle-aged elderly cohorts. It's rising, so we're seeing more and more people that are older coming to our clinics, and the prevalence is thought that 10 in every 1,000 patients will have bronchiectasis in our population. This is a cause looking at all the literature looking at what causes bronchiectasis, and quite worryingly, in up to half the patients we don't know the cause. It's unidentifiable. The commonest cause when we do find it is past infection. It could be whooping cough, pneumonia, tuberculosis. But again, it's quite often an association. They've had a past pneumonia, so we think that's bronchiectasis. We don't know really if it is or not. So this is quite a frightening slide, and this is a slide I just did the other night. And this is looking at the number of randomized controlled trials that we have in bronchiectasis compared to other conditions, and this is from a PubMed search. And bronchiectasis is here, 200 trials in the whole of our time in bronchiectasis. And look at asthma, has got nearly 11,000 trials. So there's a real lack of research in bronchiectasis to date. So that's a brief introduction. I want to actually now look at what good care should look like throughout the UK, and that's about how we should assess patients and how we should manage our services. There are some references here where we base what I'm going to say in the following slides. There's the Bts Guidelines, there's national audits we've done, there's BTS quality standards for bronchiectasis, and I'll talk about them in due slides, and again an audit of these standards. So one of the first things in the quality standards is that we said that people with a clinical diagnosis of bronchiectasis have a diagnosis confirmed by a CT scan of the chest. And then it has in the top UK versus Italy. Now you're going to see that for all the slides, and green means we're doing well, amber means a bit in the middle, and red is not so good. And this is the national audits where we're doing that in both the UK and a national audit also in Italy. And we're roughly talking several thousand patients where we've audited this. And the reason for this is, and I think we're quite good in both Italy and the UK, is that we're now diagnosing more people with bronchiectasis appropriately with a CT scan of the chest. In the past, a lot of people were relying on the plain chest x-ray that you get when you go to your GPs. Quite often they say it looks like bronchiectasis. You get coded in the GP records as bronchiectasis, and we think that's wrong. Anyone with suspected bronchiectasis should have a CT scan of their lungs. So then the next thing is that people with bronchiectasis we should look for an underlying cause of bronchiectasis, and there are certain causes that treatment differs. And we're very bad at doing it both in the UK and Italy, and that's something that we need to improve our secondary care hospitals and doing all the appropriate tests to see why people get bronchiectasis. The next thing, and we're going to talk about in more detail later, is that you can get lots and lots of organisms when you hand in a sputum sample to your GP surgery or to a hospital. And so that's important to know. It's not just one organism, it could be many, many organisms. And the commonest ones we see are Haemophilus influenzae and Pseudomonas. Pseudomonas is particularly important, and we see it in about a quarter of our patients. This is a national study looking at 2010 to 2012, and roughly about 1 in 5 patients with bronchiectasis will have Pseudomonas. And we know that Pseudomonas usually is associated with a slightly worse outcome. So the guidelines are saying, and what's good practice is that we should send sputum for microbiology assessment, and that's good practice. That means when you go and see your GP or your hospital physician, you should send a sputum sample off for culture. And we're really not very good at doing that. In the UK, we do it once a year in 62% of patients. The Italians are very poor at it. And then we say you should send a sputum sample when you get any infections prior to getting antibiotic therapy. And again, we only do that in about half the patients, both in the UK and Italy. So we need to all get better at sending sputum samples off to the labs, both when you're well once a year and when you get an infection. The other thing that I think is good practice is actually looking at the sputum and actually handing in your sputum sample to your GP and having a look at it, because by the visible look of it, we can tell what your bronchiectasis is like. A mucoid is a clear or grey looking phlegm, mucopurulent is light yellow, light green, and purulent is this horrible dark green, brown colour. And we know that if you've got this dark green, brown colour, you're more likely to have an infection, whereas if you've got this colour here that's grey or clear, you're very unlikely to have an infection. So just looking at the sputum is good practice. So the next thing is that what we've done a lot of work on in recent years is assessing how sick patients are, and I think this is we need to start doing this more routinely in practice, seeing how sick are patients when they come through the door, because that will guide investigations, guide management, and it's also useful from a patient perspective and clinicians, so we can tell you about what your long-term outlook is. I'm not going to go into this in detail, but there's the Bronchiectasis Severity Index is a scoring system that has been created, and it's looking at high-risk variables that can predict outcome. And that's based on being old. Older people are less likely to do well. If you're underweight, if you've got advanced changes of bronchiectasis on your CT scan of your lung. This is your lung function capacity. If your lung function is very low, you do less well. One of the strongest predictors of how you do is if you've had a hospital admission for your bronchiectasis in the last 2 years prior to seeing the doctor. This is 3 or more infections in a year. This is being very breathless, and this is growing Pseudomonas or other organisms. And if you add all these together, you get a score from 0 to 26. 26 is obviously very bad, and 0 is very good. Severe disease is 9 or more, moderate is 5 to 8, and 0 to 4 is mild. And what we found is when you do a scoring system like that, the severe ones are in red. The severe ones have got a poorer quality of life, you're more likely to be admitted to hospital, and you've got a much higher chance of passing away. So you can use these scoring systems to predict how a patient will do by putting all these variables together. The Europeans had a competitive score called the FACID score, and have now changed it to include exacerbations, so it's called FACID score now. And again, it's a similar scoring system to try and predict the outcome, and it's actually quite similar to our own scoring system we have in the UK. So one of the things one of the reasons why there's been a lack of research in bronchiectasis is that people say there's a lot of variation from one patient to another. We've already seen that some people can have different causes of bronchiectasis, and actually some people can have other conditions. So that's one of the reasons why there's been a lack of research. This was a nice study done in general practice in nearly 19,000 patients. And it found that actually only 1 in 3 patients had no other illness. They only had bronchiectasis alone. But 2/3 of patients had all sorts of other conditions. And actually coexisting asthma and COPD is really common in about 40% of patients. And that actually, I didn't believe that, but actually when you start looking at our own cohorts, that is true. There's a large proportion of our bronchiectatic population have other illnesses associated with it. Now, you're not meant to read this slide. This is another slide looking at a secondary care population, and it's actually quite frightening. These are all the other diseases that the bronchiectatics have. There's hundreds of them, and it's actually quite frightening. So it's just showing you that you've got to start thinking that you might have bronchiectasis, but you might have several other conditions at the same time. So there's a nice scoring system saying, well, if you do have these other conditions, can it affect the outcome of bronchiectatic patients? And there's a nice scoring system. I'm not going to go through it, but a high scoring system is not very good. So if you get associated cancer, for example, your outlook is going to be worse than other people. But let's look at COPD. That's a score of 5. And if you've got COPD and cognitive impairment is when you've got memory problems, if you've got a combination of that, you get a score of 10. And this is looking at your outcomes, and if you've got a score of 6 or more, it tells you that you've got a much higher chance of passing away compared to that have got no other risk factors. So it's really important nowadays that when we're assessing people with bronchitis, we've got to look at their other conditions. This is nice work again. It's again work looking at epidemiology studies, and this was looking at primary care databases, and it's showing you here that if you've got underlying bronchiectasis, you're more likely to have heart disease and stroke. That bronchiectasis in itself is a risk factor for heart disease and stroke. And it's one of the first publications published this year showing you that. We did some work in Edinburgh, actually, and this came out roughly at the same time. That last study was done in nearly 4 million patients, so it's quite impressive. And then we did our study in 400 patients. So, but interestingly, that actually in our study, the results really mirrored what the huge big study showed. And because we did it in a smaller cohort, we knew our patients very well, and we can risk stratify the patients. Now, post-means have developed the heart conditions after bronchiectasis was diagnosed, and we found that in severe bronchiectasis, you're more likely to get heart attacks, strokes, and irregular heart rhythms in severe bronchiectasis. And we did what we call multivariable modeling, which is where you put lots of risk factors together and to see what are the independent risk factors for developing vascular disease. And we found that if you've got moderate or severe bronchiectasis, you're more likely to develop heart attacks and strokes. So there's now quite compelling evidence that your other conditions are quite important. So, in summary, the good practice, in my view, is to consider all the conditions the patient have. It's not just a bronchiectasis, think about all the other conditions. So the next thing is about physiotherapy, and you're going to get a big physiotherapy talk, so I'm just going to tell you what the two standards are, and that all patients with bronchiectasis should see a physio, and they should teach them how to do their chest clearance properly and how often they should do it. UK, we're not bad at it. Italy, very poor, and in the States it's even worse than that. So I think it's work in progress. The thing we're less good at is if people are breathless, we would recommend pulmonary rehabilitation, and we're not very good at that. Only between 32 and 49% of patients are being offered pulmonary rehabilitation. So it's work that we should be doing better with. So what about services that we should deliver or lead from hospitals? So if you are in hospital, that you should have services that you can inhale antibiotics at home, and I think we're pretty good at that in the UK and in Italy, that if people need an inhaled antibiotic, we've got good services to offer that. We're also quite good at seeing the right people in secondary care, and that is the same both in the UK and abroad. And the recommendations for follow-up in hospitals are children with bronchiectasis, people with bad organisms. If your bronchiectasis is getting worse, you're having 3 or more infections a year. If you're on any long-term treatment with an oral antibiotic or inhaled antibiotic, if you've got a recognized cause of your bronchiectasis, or if you're very severe and needing a lung transplantation. And these are the sort of patients we're all following up in secondary care. So the next thing is that in hospitals, that when you get an intravenous antibiotic, that we evaluate you at the start of treatment and when you finish treatment. And in our audits, it's 78% of people were doing that. I was quite surprised how high that was, because I don't think that really is what happens in practice. So we'll just do a show of hands here. Is how many people that have had intravenous antibiotic therapy have had a sputum sent when they finished treatment? Hands up. Okay, very few. How many people have had intravenous antibiotics? Maybe I should have asked that first. Not many, right? Oh, it's still quite a few. So that's only about a fifth of people that get their sputum tested at the end of treatment. It's really important to know you've had an intravenous antibiotics. You really want to know, has the treatment worked? Quite often we give a therapy and we don't do a formal assessment at the end, and I think it's something we need to start doing. The other thing that people with bronchiectasis, if you do need intravenous antibiotics therapy, you should be able to get that at home, so you don't have to come into a hospital to deliver it. And in the UK that happens in about 40% of cases, where in Italy virtually no one gets it at home. We've done a lot of work in Edinburgh looking at the safety of giving intravenous antibiotic therapy at home, because you've got to remember a lot of people are middle-aged or elderly, so you want to make sure that if you are delivering at home it's safe, and it is safe, and that there's no patient died at home, thank goodness. Morbidity means that they've had some sort of upset, but that's the same in all groups, whether you're being in hospital. Early supported discharge means you've gone into hospital for a couple of days, then gone home, and domiciliary IVs means you've had them all at home. You're always going to get a small percentage of patients that are readmitted to hospital in 30 days because you're quite a severe population. The side effects were similar in all groups. Lyme problems are slightly more common when you get sent home, and that's probably because that people were doing the lines themselves, but you didn't pick up the norovirus from hospital, thank goodness. So giving intravenous treatment at home works, and it's something that should all be trying to deliver up and down the country. So the other thing is that, and I'm sure that you'd all like this, is that people with bronchiectasis should have an individualised risk and self-management plan, and we're terrible at this in the UK. Only 1 in 3 patients get it. In Italy, they're slightly better than us at 56% of patients get it. This is an example of a self-management plan that British Thoracic Society did. We've coloured it up. So it's nice. I've just given you a couple pages for you to look at. And it's quite useful. It tells you what your recommended chest treatment is. It records your antibiotic use so that the healthcare professionals can keep a note of it. And it's got a wee action plan, what to do if you get an infection, if you see a routine GP, an urgent GP, or an emergency GP. And I think it's quite helpful, and it's on the website. But we don't often give this to our patients yet, but we need to try and start giving more patients this. So the final thing to finish off a talk is just to talk about, special centres. And that means that we have a small group of special centres up and down the UK to try and deliver good quality care. The advantages of that would be is that the quality standards I've discussed today would all be adhered to, that we'd look for an underlying cause for the bronchiectasis in all patients. So we identify treatable causes, we would test for primary ciliary dyskinesia. There's only a few centres that can do that. And we'd also check for antibody deficiency, which is that some people cannot fight infections, and we'd look for that more carefully. There'd be better monitoring with sputum tests, that we get specialist physios doing what they're meant to be doing. There'd be good working with teams, the physios, nurses, pharmacists, psychologists, dietitians working together. Our patients would have self-management plans. We'd be able to deliver the antibiotics at home instead of having to come into hospital, and we'd have better assessing long-term therapies. For patients, that would assume the optimal care, allow them to take part in clinical trials as well, because they're cohorts together. They're in our own centre. We've got a patient group that are very active called Breath Takers Action for Bronchiectasis. And they've written their own website for patients. That's it there, and that keeps patients updated about what's going in bronchiectasis. It offers it's good for teaching for under and postgraduates and other healthcare workers, and it also offers opportunities for research and also for benchmarking up and down the country. So I hope I've described to you what good quality care is, and I'm happy to receive any questions.